ऑडियो वीडियो चेक कर लो। हेलो हेलो। Okay, so we just got the confirmation that the audio and video is fine. Once again, sorry for the delay in starting the lecture. Okay, myself, Dr. Rijul Agarwal. I'm the orthodontic faculty at DAMS. So today's topic is transverse expansion in orthodontics. So we'll be having a brief discussion about it, and we are also going to see few images of the appliances which help us in transverse expansion. So the topic, as I've mentioned, is transverse, means in the sagittal, in the coronal direction. So the most important thing for transverse expansion is the sutural split, that is the transverse growth of the mid-palatal suture is continues up to 16 years in girls and 18 years in boys, and at the age advances it becomes increasingly tortuous and interdigitated with increasing age. So with increasing age it becomes difficult for us to achieve transverse expansion using simple appliances. So after a certain age, when the suture has completely ossified, we need to have a surgical approach for the same. So the growth in length, so as we know, what we are discussing right now is the transverse growth. The hard palate also continues to grow lengthwise until the age of 13 to 15 years. Why? Due to the growth in the transverse suture. And how? Due to the apposition of bone on the posterior margin of the palate. So it increases its length and in transverse direction as well. Okay, so what are the appliances? So in childhood, the expansion, any simple expansion devices, as we have done in our graduation time as well, so using simple jack screw we can achieve transverse expansion. Okay, so as the age advances, during adolescence we require considerable forces to create microfractures before the suture can be opened, and late teens the suture has ossified, there is interdigitation and areas of bony bridging across the suture so developed, so the skeletal maxillary expansion is not possible without fracturing the suture. And how do we fracture the suture? Using surgical approach. Now we need to have a surgical approach for fracturing the suture so that expansion can be achieved. Okay, so before beginning with the appliances, we need to know certain histological facts about the transverse suture as well. So it was described by Jork and Helm. Okay, so they divided the growth of the mid-palatal suture into 3 stages. First stage is the infantile period, that is 2 years of age. The mid-palatal suture is broad and is Y-shaped, with the vomerine bone placed in a V-shaped groove between the two halves of the maxilla. Okay, so these are the two halves of the maxilla, and in between them comes the vomer bone from the top, and it's in the V-shaped manner. Okay, now as the age advances, as we have already told you, the juvenile period, that is by 9 years of age, the sutures become wavy and longer in the vertical aspect. Okay, and the junction between the maxillary bone, that is from the posterior anterior side, and the palatine bone becomes higher and assumes more of a T shape. Please note these V-shaped, T-shaped descriptions are important from your MCQ point of view. Okay, and lastly, that is the stage 3, the adolescent period, that is 13 years of age. The suture becomes more tortuous, coarse with increasing interdigitation, which mechanically interlocks as in a jigsaw puzzle manner. Okay, so the interdigitation of the articulation between the palatine bone and the maxilla do not permit separation without the occurrence of fracture. So because of the increasing intertortuosity and digitation, we cannot separate the palatine bones or the palatine halves which are necessary for transverse expansion. So for doing that, we need to fracture that suture before we can achieve that expansion. So the closure of the mid-parietal suture progresses more rapidly in the oral region than in the nasal surface of the parietal wall, and the intermaxillary suture starts to close from posterior to the anterior region. So please, these points are very important. The suture closure starts from posterior to the anterior region, and it's more close or more mature in the oral region than in the nasal surface of the parietal wall. So therefore more considerable forces are required to separate the suture at the oral region than at the nasal region for us to achieve the transverse expansion of the maxilla. Okay, so this is the histological overview of the mid-parietal suture. So what are the clinical features? First, the normal transparietal width. In mixed dentition it is 33 to 35 mm, and in adults it is 35 to 39 mm. Okay, so here comes the rule of 34 by 27. So this norm was given by Handelman. He said that transarch width in the first molar and in the first premolar region up to 2 decimal places is this much, and in the mandibular region it is this much. Okay, so the data from this evolved into the 34-27 rule for the maxilla and 32-25 rule for the mandible. Okay, so students, please note, so what we do clinically is we measure the transparietal width at the first molar and the first premolar region. If it's less than that, then it's an indication for going expansion. Okay, so this is the clinical way of diagnosing whether this case is indicated for rapid maxillary expansion or not. Okay, next is that 10 to 12 mm is considered as the upper limit of the maxillary skeletal expansion correction which can be achieved. Okay, so there is a limit, as we all know, for transverse expansion as well, so that is 10 to 12 mm. Okay, so this was the clinical way of diagnosis. Next, on a PA or a posterior anterior cephalogram, we can diagnose it by calculating the ratio of the maxillary and the mandibular width, and the ratio should be 80%, and the ratio of the nasal cavity to maxilla ranges from 40 to 42%. Okay, if it's less than that, then it's an indication of expansion. Next comes the maxillomandibular differential. So the mandible width is measured from a point known as antigonion. This is located and seen on a posterior and PSF, and similarly the maxillary width is located from a point J to J. Point is defined as, you can say it as jugale, Jugale, and AG is antigonion. So from this and this, the differential should be approximately 20 mm. Okay, again, if it's less or more than that, accordingly expansion of the either of the jaw is indicated. Lastly is the use of occlusal radiographs to analyze the sutural status, whether it is ossified or not. So what are the indications? Also, one more thing, which this is the clinical method, this is the radiographic method, and model analysis. If you remember, the most easiest way, or the one which we used to do during a graduation, that is the Pond's analysis, the Linderhardt analysis. Okay, the Ashley-House index, the Corcus analysis. These all are also used for assessing a case whether it's indicative for maxillary expansion or not. Okay, so what are the indications for a case to be considered for transverse expansion? First is the presence of posterior crossbite, which can be either unilateral or bilateral. Next is elimination of interarch transverse discrepancy prior to orthopedic intervention in class 2 malocclusion. So as we know, what we do in class 2 malocclusion, we advance the mandible. So what happens in those cases? Priorly, there might not be any transverse discrepancy, that is, there won't be any crossbite present, but once we advance the mandible, there is occurrence of crossbite. Okay, so for that we need to go for transverse expansion. Remember, if you remember the image of twin block, there used to be a RME screw or a jack screw present in the maxillary appliance. Okay, it is because of for this reason only. Next is activation of circummaxillary suture in class 3 correction. So likewise in class 3 correction, what we need to do is advance the maxilla. So for that we need to activate or break the circummaxillary suture so that the maxillary expansion can be done easily. Okay, or advancement. Okay. Next is cleft cases with collapsed maxillary arches. As we know, in what happens in cleft palate, the palatine shells fail to fuse, leading to transverse deficiency. Surgical repair can only cause or lead us to a sutural closure, but we need to have a transverse arch width as well. So in those cases also we need to go for expansion. Lastly, increase arch perimeter in tooth size, arch length discrepancies. So certain crowding cases can also be avoided or corrected using maxillary arch expansion. So what are the contraindications? First is absolute, last is relative. Relative is closed mid-palatal suture, that is a relative contraindication. Why? Because I've already told you, in closed mid-palatal suture cases, we can expand with the help of surgical means as well. And what is the absolute contraindication? Single tooth cross bite, vertical growers, anterior open bite. Vertical grower and anterior open bite are somewhat linked. Why? So because in a vertical growers, if we do expansion, it will further lead to increase in the vertical. Okay, why? Because the posterior teeth now will come, if there is a cross bite present, when we expand, the posterior teeth will cause a wedge effect and will lead to further increased open bite or further increase in opening the bite anteriorly. Okay, that's why it's an absolute contraindication for us to do expansion in vertical grower and anterior open bite patients. Next comes the appliance. So first of all, the name of the scientist, that is Emerson C. Angel. Student, please don't confuse this name with Angle. It also in your exam they can also give you in the short form as EH Angle, or here it is Angel. So Angel is the father of rapid maxillary expansion and Angle is the father of modern orthodontics, who evolved all the pin and tube, the edgewise appliances were all given by EH Angle. It was Edward Hartley Angle. Here it is Emerson C. Angel. Okay, so there are two types of fixed rapid. RME stands for rapid maxillary expansion screws. So there are tooth borne and tooth and tissue borne. So what is the difference? How will you identify? First of all, some name, then I'll tell you the identification point. So tooth borne appliance में there are two expansion appliances. First is Isaacson type and next is Hyrex. Hyrex is the most commonly used. Hyrex stands for hygienic rapid expander. It was given by William Biederman. And Isaacson type is a mini expander. Why it's named as mini? Because it was developed at University of Minnesota. And next is the tooth and tissue borne appliances, in which comes two types, that is Derrick's filler type and Haas type. So how we will differentiate between tooth and tissue? Tooth and tissue will have a support from the tissue region as well. How? There will be an acrylic coverage will also be present like this. Okay, so an image, if there is in exam you get an image with the acrylic coverage present, it's most likely, or it's 100%, you can say it's a tooth and tissue borne expansion appliance. And here no absence of acrylic coverage, it's a completely tooth borne expansion appliance. Next important point comes the pitch of the screw. So what is a pitch? Pitch is the amount of expansion done by one complete turn of the screw. Okay, so in the mouth, when the screw is present, we can only done when we do one turn, that is by 90 degree, it opens the screw by 0.18 mm. So pitch of the screw is when we turn the screw completely, that is by 360 degree turn. So for that we need to turn the screw by 4 turns. So the total pitch will come out to be approximately between 0.72 to 0.8 mm. So 4 turns, that means 360 degree is the called as a pitch of the screw, and it leads to opening of the screw by 0.72 to 0.8 mm. Okay, next the most noticeable feature of expansion after doing RME is the appearance of midline diastema. Okay, so the amount of incisor separation is roughly the half the amount of jack screw separation. So supposedly these ends of the jack screw open by 2 mm. Approximately 1 mm of midline diastema would be seen in rapid maxillary expansion, and it won't be seen in slow expansion devices. Okay, and it automatically closes within 3 to 5 months. How? Due to the action of transseptal periodontal ligament fibers. So on an average, if we increase 1 mm, increase the premolar width, leads to the gain of arch length by 0.7 mm. So these are the some clinical numerical data which is very important for your exam point of view. So this is the clinical effect of RME. So clinically, without radiograph, you will see the appearance of midline diastema. If on an occlusal radiograph, you will clearly see a mid-parietal suture opening. Okay, next is activation schedule. So according to TIMS, for patients up to 15 years of age, 90-degree rotation in the morning and in evening, and in patients over 15 years of age, 45-degree activation, that is 4 times per day the screw should be turned. Why? As I've told you that with increasing age there is increasing interdigitation of the screw, so more amount of force is required for us to open the screw. Next protocol is by Zimbring and Isaacson. So in young growing patients, 2 turns each day for 4 to 5 days and later 1 turn per day till desired expansion is achieved. And in non-growing adults, we do 2 turns per day for first 2 days, 1 turn per day for next 5 to 7 days, and 1 turn every alternate day till desired expansion is achieved. So typically the rapid parietal expansion that is done with a jack screw is activated at the rate of 0.5 to 1 mm per day. Okay. So what are the post expansion changes which are seen? So skeletally in the maxillary half, the 2 axillary halves of the maxilla rotate in both sagittal as well as coronal direction. So in coronal direction they move away from each other, that is the frontonasal suture moves away, and in sagittally they move in downward and forward direction. So what will happen if the maxillary halves moves in downward and forward direction? Below is the mandible, it will also move in downward and forward direction. So what it will lead to? The teeth need to get in contact, or it will lead to extrusion of molars. That is why in vertical growers expansion is contraindicated. Okay, next in the nasal airway region, so increase in the intranasal space, the airflow resistance reduces by 70 to 80%. Okay, next is the difference between RME and the slow expansion devices. So the rate of expansion in RME, that is rapid maxillary expansion, is 0.5 to 1 mm per day, whereas in slow expansion it is 0.5 to 1 mm per week. The time required for complete expansion is 2 to 3 weeks for around 10 mm expansion, whereas similar kind of expansion, that is 10 mm, is achieved in 10 weeks. The force exerted is quite high, that is 10 to 20 pounds, whereas it is 2 to 4 pounds in slow expansion. RME being rapid in nature, that then therefore it is less physiologic, whereas slow expansion is more physiologic in nature. And last point is very important, that is the net skeletal to dental effect is same in both cases. How? We'll just understand this with the help of a graph. So these are the graphs of a rapid expansion and a slow expansion device. So in cases, first graph shows the amount of expansion versus the time duration. So in first case, when we do rapid expansion, there is more skeletal effect initially than the dental effect, but as the time passes, the dental and the skeletal effect coincide, leading to the total effect of being same. Whereas in slow expansion, from the beginning itself, the skeletal and the dental effect are net similar in nature. That is why the net effect is same, but initially there is more skeletal effect than dental in rapid expansion, whereas it is equal from the beginning in slow expansion devices. So a question, the ratio of skeletal to dental expansion obtained initially. Here the question is asking about initial, not the net or final effect. So the answer is 4:1. Initially it is 4. Had the question about been net or final or total, any such word, then the answer would have been D, that is 1:1. Here they are asking about initial effect. So you need to be very careful with the language of the question and the words they are asking. So next comes the appliances used for expansion. So first are the appliances for slow expansion. First is a simple jack screw, which we have used and seen innumerable times during our PDS. Next is the coffin spring. So this was given by Walter Coffin in the year 1877. So this is how a coffin spring looks like. Okay, we just open up the arms so to achieve the expansion. So later on, this coffin spring was modified by Ricketts to give the quad helix appliance. So it is made up of 0.038 inch wire, and the force applied is approximately in the range of 200 to 600 grams. What is a quad helix? How it's activated, we'll see in the next slide. Lastly is the mandibular expansion device. It's known as a Schwartz appliance. Okay, so this is the image of a Schwartz appliance. The expansion schedule of a mandible or a Schwartz appliance is once per week. Okay, so next is the quad helix appliance. So what are the parts of a quad helix appliance? So there are, first of all, 4 helixes, 1, 2, 3, 4. These are the anterior helix, and this is the posterior helix. Next are the bridges. This is the anterior bridge, and these two are the posterior bridge. And lastly are the 2 arms, that is the posterior arms. Okay, so why was this called coffin spring modified into quad helix? Was because of this reason. Now we can students, you can see we can achieve desired amount of expansion either in the anterior or posterior region by operating or opening different helices. Okay, earlier coffin spring was only able to achieve expansion in the posterior region. Now we can achieve expansion either in the anterior or posterior region depending upon where it is required, and how it is done I'll just show you. So next is the image of the instrument which is used to activate this quad helix. This is the 3-prong plier. This is the topmost view of the plier, that is a 3-prong plier. This is how it looks, 3-prong plier. Okay, so next comes how to activate it. So for activating this appliance, first of all, this appliance is taken out of the patient's mouth. Okay, so once we activate this anterior bridge, what will happen? The posterior region, this opens up. So what it will do, it produces expansion in the exclusively in the molar region. Okay, diagrammatically if you want to see, if we activate this, the molars move out, and so anterior bridge, expansion in the molar region. Next, if we close or activate one arm, that is the posterior bridge. Now here we can activate either one side or both side as well. Okay, so if we activate the posterior bridge, what will happen? The premolar and the canine region gets activated. So likewise we can activate both the arms or only one arm depending upon the expansion required. Either it's a unilateral crossbite or a bilateral. If it's a unilateral, we can activate one arm. If it's a bilateral, we can activate both arms. And likewise, if we want expansion just in the premolar to canine region, we just need to activate this posterior bridge. Okay, so next These were the activation of the anterior and posterior bridge, and likewise the amount of expansion which we want. Okay. Similarly, we can open this helices as well. Okay, so if we open the anterior helix, what will happen? This region will move out. So what will happen? There will be expansion in the molar region. And similarly, if we open the posterior helix, this whole arm will go out. So likewise there will be expansion from canine to premolar region. So depending upon the amount of expansion desired, the expansion region, different parts or different regions of the quad helix can be activated so as to achieve the desired amount of activation. So this is the advantage of quad helix appliance. So for you to remember, first of all, in quad helix it was given by Ricketts, the wire from which it is made, the force which it applies. Next comes the diagram of the quad helix, the appliance or the instrument used to activate it, and lastly किस ब्रिज का एक्टिवेशन या किस हेलिक्स का एक्टिवेशन करने से किस रीजन में एक्सपेंशन होगा, you should know. Okay, beyond that no question can come from quad helix appliance. Okay, next a newer kind of appliance, but it's not so new because approximately every exam, be it INI or NEET, is asking about this appliance, that is the nickel titanium expander or the NiTi expander. So first of all, this is the image of a NiTi expander. It is comparatively new as compared to the previous appliances which you have seen. It was given by Wendell V. Arndt in the year 1993. It's a fixed removable type of expander. Why? So we can fix, how it's fixed, it's inserted into this lingual cleats which are attached on the first premolar region. So through this it is fixed, and if we remove this hook, open it, it can come out of the cleats as well. So it's a self-activating thermally activated expander, exerts a slow continuous uniform type of force. It is categorized as SME, that is SME type of expander. Okay, that is slow maxillary expander type of appliance, that is considered a more physiological type of movement. Next advantage is that it combines the effect of shape memory and the super elastic properties which are of NiTi nickel titanium. They are available in 8 different sizes, that is from 26 to 47 mm, and generates a force of 180 to 300 gram. So depending upon the expansion which is we desire, we select the size. So what we do is, we have a armamentarium, from that we need to select a size. Supposedly we desired expansion of 26 mm. Okay, we select that expander. The width of this expander will be 26 mm outside the patient mouth. Now what we do is, we cool down this expansion appliance either in ice or there is special liquid as well. Basically it is a solid carbon dioxide. So once we cool it down, we can mold it outside, and through molded or through compressed form we insert it into the patient's mouth. So through the warm intraoral temperature, the NiTi has a shape memory effect. So what will do, it will come back to its original size of 26 mm, and now it's inserted or attached to the molar. So along with it, it will take those molars away from each other. Okay, so through this method desired amount of expansion is achieved, and since it's a slow maxillary expander, it exerts a more physiological force. Okay, remember A to M transformation. So this A to M transformation, that is the shape memory, occurs inside the mouth. Okay, then outside the mouth we cool it through ice and back to super elasticity. So now here this is the shape memory effect, and here it is super elastic. Super elastic means now we can bend it, fold it and bend it and compress it and inside the patient's mouth. Next are the fan expander and a butterfly expander. So first is the fan expander. It is given by Scilino and Modica. And what is the advantage? Here there are 2 types of screws. So now we can achieve anterior expansion as well. How? If we just open this screw, it will open up like this. Sorry, it will open up like this. Okay, and if we want to expand it posteriorly, we just need to open this screw and posterior expansion. So differential rapid expansion can be achieved through this fan shaped expander. So it opens like a fan, if you remember the Chinese fan. Okay, so it can help us with anterior and posterior expansion as well. And next is the butterfly shaped expander. So just posterior expansion, the arms are modified like this. It's a butterfly type expand. So for certain protocols are fixed. So for 4 mm of arch expansion, we can do it with a fixed or removable appliance. For 5 to 12 mm expansion, fixed maxillary mid parallel expander with jack screw is required. And for more than 12 mm, surgical rapid palatal expander with jack screw is required. These are the value base. In addition to that, you need to see the status of the intermaxillary suture as well. Okay, so combined with the clinical features and the amount of expansion desired and the sutural status, we design our appliance and proceed accordingly. Okay, so lastly, a few questions. Which of the following conditions, if present, render a patient less than ideal candidate for rapid palatal expansion? Full cusp crossbite with skeletal component, it is an indication. Open bite tendency, as I've already told you, if we do expansion in open bite or vertical grower patient, it will further increase the anterior open bite. Some degree of dental as well selected construction initially, correct. No pre-existing dental expansion, correct. So open bite tendency is a contraindication for expansion. Lastly, a previous year question, that is a type of force exerted by an expansion screw. So it exerts a interrupted force. We take out the appliance, the force level drops to 0. Okay, so this was a small topic or small discussion on transverse expansion in orthodontics. Few important points for your upcoming exam as well. If anyone has any doubt, you can write to me in the comment section, or you can tag us, you know where to reach us. Okay, so with that, if anyone has doubt, I'll wait for a minute or two, otherwise I'll close the session. Exam for a NEET or NIA point of view, this NITA expander image and all very important, quad helix important. Okay, the difference between slow and rapid expansion is important. Okay, the images are important, the clinical features, indications, the histological aspect. Okay, these all are important from this expansion topic. It's a small topic but carries a considerable weight in your exam, especially from image based point of view. Okay, so we'll be discussing these images once again in your revision series starting in the month of January. Okay, so I think no one has any doubt, so I'll close the session. Okay, so once again, thank you everyone for joining. Okay, thank you. Good night.